to be talking about the schizophrenic spectrum and other psychotic disorders. But to start out, I want to give you a picture of what schizophrenia looks like today. I'm going to call this particular person Jacob. That's not his real name. But I dealt with him maybe 20 years ago, something like that. And he had come to the church and he'd been diagnosed with schizophrenia. And the main thing that you saw is that he was always pacing back and forth. And he always had a dry mouth. And he was struggling with all sorts of sexual issues, and all sorts of things would go through his mind. And the way he described things was that it was like there were two chains of thought going through his mind, and they would intersect and confuse. So there were like two things going on at all times. And so he couldn't really concentrate on things and couldn't really sort things out. And he was struggling with all these different issues. I helped him learn that in the spirit he had power over all the spirits that were talking to him, the voices that were talking to him, the hallucinations, the other things that he was having, and he was actually able to control them doing that. But he felt, well, since I can control them now it's okay if I do them. And so therefore and pretty soon the spirits weren't reacting to him anymore. He didn't have authority over them because he didn't really believe they did. And he was struggling, and they would get him like a job coach, and during the day he'd be going to a day hospital and so on, and they would help him out, and he got a job coach. But his jobs never lasted very long. They'd be working with him and so on, and eventually he would just be overwhelmed, throw up his hands, and quit. So that would happen over and over again. At one point in his life, he did get married, but the marriage didn't last very long. So do you see, we have a combination of a lot of things going on in this person's life. At one particular point at that time, I was a pastor, and he was coming to my church, and right in the middle of one of my sermons, he wanted to deal with one of his counseling issues right in the middle of the congregation. Well, I'm wearing two hats, which isn't a good thing, so what do you think I had to do? I'd say, will you please sit down, I'll talk to you afterwards. Well, that was enough. He relapsed and had to be hospitalized again. And so it's sort of a constant ongoing struggle. And his social skills weren't very good, so he would get himself in situations like he came to a support group and he asked some ladies to give him a ride home. Well, they were absolutely freaked out of their minds, And so there's all these kind of issues that are going on that sort of are a cumulative thing, and that's why it's hard to deal with this. See, how much of this is physical? Well, one of the things we have to realize is he was on Haldol, which has a lot of side effects. And see, him pacing back and forth, that was the medicine. That wasn't schizophrenia at all. Okay? See what I'm saying? The dry mouth was the medicine again. And so you have to decide how much of this is the medicine that they're taking. And the way they deal with people today is they try to keep him in the community, put him on SSI, so he was getting sort of paid. One of the issues I brought up with him, what would happen to you if you got healed? Well, I don't know. I don't think I could make it in the real world. So he had a vested interest to probably not get healed, to stay on SSI. And so you have all of these issues. And of course, the spirits were doing interesting things, and he would have different situations that would come up. But we got his symptoms helped out quite a bit, which is you can do, and so on. And so then they changed his diagnosis to schizoaffective, because he did have some emotional ups and downs and some other things going on. And so do you see in DSM-5 and so on, it's based on symptoms. So if people get better, you might change their entire diagnosis. But we want to dig into this a lot and really try to understand what we're talking about when we're talking about psychosis. But let me remind you about something we've said before. See, what is psychosis? Well, first we have, let's call this normal or healthy over here, okay? And that means you have a person that has the needs for self-worth, significance, love, and security, and they're actively pursuing those in some means. It might not be successful, but they're trying to meet those needs, and they're having some success. That's what we'll call healthy or normal. Then you have what we call codependency, which is people are now so overly dependent on other people or overly dependent on themselves that their situations in their life get all messed up in relationships. We call that codependency, or they're dysfunctional. But at some point when they can't meet their needs, another term for that, by the way, is neurosis. Neurosis means I just want to be safe. I'll do anything to be safe. So that's the dysfunctional realm, okay? But you can be safe, you can still survive, you can hide in your house, you can do nothing. But what happens if you still can't do it? What if you're not getting your needs met and you desperately want to get your needs met? Then you can go into unreality. And unreality is psychosis. That means that you're now making up a world and you're living in another world that isn't real. And you might think that you're Jesus Christ. Because if you were, would you be worthwhile? Well, that's a way of coping, isn't it? And the problem is when we get into psychosis, the person isn't defending their brain, and therefore spirits can take advantage of that, and you can have these spirits telling them to do all sorts of things. This just recent attack on the Navy base, what was the problem? Psychosis. He was believing there were people harassing him, and he was having these different thoughts and things. You'll find out that that's all part of psychosis. And then spirits take advantage of that and people act out on it. Now, some people will tell you that it really isn't spirits, it's just the brain malfunctioning. Let me ask you a question. If it's just the brain malfunctioning, why doesn't the brain ever tell people to do good things? Why does it always tell them to do evil things or to kill themselves, or like one kid stab himself in the throat with a pen, or all sorts of stuff like that? So that's why I believe these are really spirits, but they take advantage of the vulnerabilities that are there. And of course, what does that mean? You're going to have to deal with the vulnerabilities as well as the spirits when we deal with all of this stuff. So let's take a look at this. The symptoms of psychosis, it's a break with reality. You're trying to cope some way in your own life to make things okay. And so we have a number of different type of symptoms, and you need to sort of learn these, okay? The first one we're going to call delusions. They're a fixed belief not amenable to change in the light of conflicting evidence. And you can have non-bizarre delusions, meaning that, well, this could really happen. And then you can have bizarre delusions, which means, no, come on now. You know, is that really happening? No, we don't believe that those things really happen. And what are the most usual ones? Well, the first one is persecution. I've had a number of clients that have had these kind of delusions. I had to give them a delusional disorder because one lady, as an example, believed that one of the people in the family had turned some people in for drugs, and this drug cartel was putting chemicals in her backyard to make her sick. See, that could really happen, right? So that would be a non-bizarre delusion. Another guy was believing that the neighbor was spying on him all the time. Delusions of reference. The patient feels that they're being talked about, perhaps in the press or TV, or that certain gestures, comments, or environmental cues are directed at themselves. Don't you see that everybody in this classroom is really watching me and they're out to get me? Grandeur. That there's somebody great, and everybody ought to just, you know, when you walk in, everybody in the classroom ought to stand up and clap. Because you're so great and you're so absolutely wonderful. Some exalted position, ability, wealth, or fame, such as being God or being a movie star. Jealousy, and this one unfortunately we see quite often, that someone is just so convinced that their wife has had an affair on them. I had a person like that. We finally got him to back down, but a year later he divorced her. No evidence whatsoever that there was an affair going on, but he was so convinced that it was true, and we couldn't change his mind. Poverty. They face destitution. They might have thousands or millions of dollars, but they still feel like they're in poverty. Somatic, that means ill health. They have some terrible disease. Of course, the doctors can never find it. Erotomatic, they believe that somebody else is in love with them. Guilt, the unpardonable sin or some grave error. If you ever get a client and they're a Christian and they believe they're not saved or they've committed the unpardonable sin, watch out. That's one of the devil's most usual tactics, to push people over into psychosis and into unreality. Because think about this. In life, if you'd really committed the unpardonable sin, what's your future? And there's nothing you can do about it. So do you see how that would push a person over the edge to cope in unreality? And so that's a sign, once you see that, to realize you're dealing probably right on the edge of psychosis if they're not in psychosis already. What is the unpardonable sin? It's really rejecting Jesus, rejecting the Holy Spirit for your entire lifetime. And so if they really want to do right, have they committed the unpardonable sin? If they really believe in Jesus, have they committed the unpardonable sin? No. Impossible. And then nihilistic, that some major catastrophe is going to occur and you've got to save the world from this major catastrophe. But can you see how all of those things could really happen? The bizarre types, though, that thoughts are being removed by some outside source, or thoughts are being planted in your head by some outside source, or radio waves are affecting you in some place, or your thoughts are being read. Passivity, you're being controlled and manipulated, you are just a puppet. Thought control, you believe ideas in your mind are being totally controlled by some outside source. One's body or actions are being acted and manipulated by somebody else. So do you see the difference? Those are the bizarre ones. Now see, some people get these delusions mixed up with hallucinations. But the delusions are just a thought pattern, okay, where a hallucination is a false sensory perception. And you can have auditory hallucinations as well as visual hallucinations. In fact, the auditory ones are the most usual ones. And what form do they usually take? Voices. And so we think that some of those, we're not saying everything here because it's more complicated than that, some of those are spirits that are speaking to that particular person. And sometimes they'll even hear a conversation between two of them. There'll be one spirit talking to another spirit, and that spirit's talking to that one, going on in their head. So auditory ones are the voices, the most common. But visual hallucinations are like real. I mean, they're really seeing these particular things. They must occur when the person is fully conscious. It's not when they're in delirium. It's not when you're waking up or you're going to sleep. And it's not illusions that are misinterpreted of sensory perception. As an example, a lady that I was dealing with that really had jealousy problems and so on, but she was pretty much blind. So what do you think was happening? She was seeing things and saying that her husband was doing certain things, but she couldn't really see very well, so those things were really not happening. They actually set up a video camera to prove to her that the stuff that she thought she was seeing and thought was happening was really not happening. Or people that don't hear very well will fill in the blanks. See, those are not hallucinations. Within the normal range of experience, but could be part of religious experiences in certain cultural aspects. Do you see what they just said here? That's a quote from DSM-5. They're saying that these hallucinations could also be spirits. They could also be things that are affecting you, and they're actually admitting that in that particular line that was added in DSM-5. The next characteristic is disorganized thinking or speech. Derailment or loose associations governed not by logic but by rhymes. They're sort of like rhyming, going along, and instead of this connects to this, connects to this, connects to this, you know, it's all mixed up and you can't make any sense out of what they're saying. Answers to questions may be obliquely related or completely unrelated. Must be so badly impaired, they call it a word salad, that it materially interferes with communication. So when you're hearing something that's just going off and you can't track them, that can be one of the characteristics of psychosis. Disorganized behavior, bizarre behavior that has no goal-oriented or apparent reason, like taking off your clothes in public, repeatedly making the sign of the cross when there's no reason for doing that, assuming or maintaining certain postures. Catatonic behavior, decreased reactivity to the environment, including resistance to instructions, maintaining a rigid, inappropriate, or bizarre posture, or complete lack of verbal or motor responses. Now, this can be a symptom of other problems too. One particular guy that I was working with, he would just sit there and freeze. He'd stay like that for 20 minutes, get up and walk off. Catatonic excitement, purposeless and excessive motor activity, stereotype movements, staring, grimacing, mutism, or echoing of speech. And the last one we have is called negative symptoms. And the idea is where you're going to put this all together. And we're going to find out that in the past we had particular categories for each one of these. We don't have those anymore. This is considered to be one overall spectrum. Okay? Reduced range of expression or emotion, flat or blunt effect. Markedly reduced amount or fluency of speech. Loss of motivation to do self-initiated purposeful activities. Decreased ability to experience pleasure. That was one of the things that Jacob had, is he just couldn't experience pleasure, so he would just go after everything to try to feel something. Gives the impression that something has been taken away. In other words, you meet them and they're not there. They just don't react, they just don't do things and so on. That's the negative symptoms. Reduce the apparent textual richness of the patient's personality. So those are all the different characteristics, okay? So now, what are the different types of psychotic disorders that we're looking at? Okay, the first is what we call schizotypal personality disorder. Now, how are personality disorders different from the rest of the things we're talking about? They're usually a lifelong situation, and they may not be as extreme as what you're seeing. And the order we're going to go through these is what they consider the least extreme to the most extreme as we go through these different possible psychotic disorders. This person has a very strong fear of rejection, handicapped in all interactions with others, including acute discomfort in close relationships, cognitive or perceptual distortions, or behavioral eccentricities. Feel intensely lonely. Striking deficits in obtaining reinforcement of any kind, paralyzed, incapable of meaningful action. They have withdrawn, fantasy, and other eccentric behaviors that are used to escape overstimulation or unmanageable stress. So this is just a lifelong, this person is just odd. See, they're not really necessarily seeing a whole lot of hallucinations. They might be seeing a few. They're getting different pieces of this all put together, but their personality is just odd. They don't fit in. They don't relate to other people. Criteria: beginning in early adulthood, experience isolation, discomfort with social relationships, and has perceptual or cognitive distortions or peculiar behavior. Ideas of reference: behavior influenced by odd beliefs, unusual perception and body illusions. Paranoid or suspicious ideas, effect constricted by range and inappropriate on topic. Odd behavior or appearance, no close friends or confidants except close relatives. Marked anxiety. But those are just the whole way the person sort of looks. How are you going to treat a person like that? Well, you're going to help them try to function and teach them social skills and so on and so forth to help them function as well as they possibly can function. So that's number one. And we're getting in the increasing order here of difficulty in problem. The next one is called a delusional disorder. This is overall 0.2%. Criteria: one or more delusions for a month or longer. Hallucinations, if present, are not prominent or related to delusions. Apart from the delusions or its ramifications, function is not markedly impaired. This person just believes something very interesting, like the lady I mentioned about that her yard was being laced with chemicals that were affecting her. The rest of her was functioning fairly normally when you have a delusional disorder like this. If manic, the major depressive episodes have occurred, they're not very important in what's going on here, and not a substance, medical, or mental disorder. Now you can specify, in all of these, remember we said specifiers, what are they? How you just clarify what it is. So in this case, you have to specify the type of delusion that the person has. And the different delusions, one is the erotomatic. Remember the person that feels so everyone's in love with them? The grandiose, the jealousy, the persecution, the semantic, the mixed, bizarre, unspecified. And then you even give like first episode, currently acute, currently partial, full remission. All of these different specifiers to explain what kind of delusion you're dealing with here. Severity. You have to rule out and decide whether this is a major problem. Within this area in DSM-5, they give you a whole checklist to determine severity, whether it is mild, moderate, or severe. So a person that just has a delusion, they're functioning pretty good otherwise, you're going to possibly give them a delusion disorder, assuming you can't change it. Next, brief psychotic disorder. Criteria: at least one of the following: delusions, hallucinations, disorganized speech, gross disorganized or catatonic behavior. So any one of those things, at least 1 day but less than 1 month. So if somebody has a problem like this and it lasts more than 1 month, what do you know? You can't give them this diagnosis. This is a brief psychotic break. Not a major depressive or bipolar disorder with psychosis, which is another thing that it could be. Specifiers: with or without marked distress, postpartum onset. Yes, some people will go into psychosis and postpartum depression. With catatonia. Severity, again, mild, moderate, or severe. Next is schizorra disorder. That's like schizophrenia, only it ends up with RENIFORM. And it's another type of disorder, again, not as strong as schizophrenia. 2 or more of the following during a 1-month period, including at least one of the first 3. Delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, negative symptoms. Lasts at least 1 month, but less than 6 months. So do you see what we're saying? The brief one was what? Up to 1 month. This one now is 1 month to 6 months. And then we're going to see when we get to schizophrenia after this. So in schizophrenia, the criteria is a split between thought and emotions and withdrawal from reality. By the way, it's not split personalities. Some people think schizophrenia is multiple personalities. That is dissociative identity disorder. Okay? Symptoms: for at least 1 month, the patient has at least 2. Delusions, hallucinations, speech, severely disorganized or catatonic behavior. Decreased level of functioning in 1 or more areas such as work, impersonal relationships, or self-care. Continuous 1 symptom for at least 6 months. So now we go to 6 months and beyond, and we're going to say this is a permanent thing now because they didn't get well in 6 months, and we're going to call it schizophrenia. Not due to mood. Schizoaffective disorder is ruled out. And we're going to find out, see, the combination of schizophrenia and a mood disorder like bipolar is called schizoaffective, and it's considered worse than schizophrenia because we're now dealing with 2 things that are mixed here. It's not a medical substance. It's not in the autism spectrum disorder or communication disorder, because you can have prominent delusions, hallucinations in those also. And then we have schizoaffective disorder. Criteria for schizoaffective disorder: uninterrupted period of major mood episode with schizophrenia, delusions and hallucinations for 2 or more weeks in the absence of a mood disorder during a lifetime duration of illness. So what we're saying is you're going to have to be able to identify both the mood disorder at some time and the schizophrenia at some time to be able to give this diagnosis. Mood symptoms are present for a majority of the duration. It's not a substance, it's not medically induced. And specifiers: bipolar type, depressive type with catatonia, first episode, current with acute, partial, full remission, continuous, unspecified, and then the severity scale again. In this particular case, the suicide rate, by the way, is about 5%. So you have all of these different things that are going on. But the things you're going to actually see more of probably are the next category: substance and medical induced psychotic disorder. As an example, I had a man come in and he called me up and he said, people are pointing lasers at me. You know, lasers, guns, you know, they're about ready to be shot. He put a little dot on you and they're, you know, and he was seeing all of these kind of things. Well, he had been on meth for a week. So do you see what's happening? And as we talk about schizophrenia, you're going to see there's a close relationship, because meth deals with dopamine. A lot of schizophrenia has to do in excess of dopamine. And so we're going to look at all that and go deeper into this whole thing and understand this more. You can also have catatonia associated with another mental disorder. Now, back in DSM-4, we had all these categories. I'm just going to mention them to you so you understand. They don't exist anymore, because we see this now as one total problem. Do you see what I'm saying? And it's a severity scale versus that we have this problem, or we have this, or we have this. I think part of the problem is that people were switching, and so they realized this isn't working as well. But back in DSM-4, before DSM-5 came out, we had the paranoid type of schizophrenia, we had the disorganized type of schizophrenia, we had the catatonic type of schizophrenia, the undifferentiated type, that's some of all 5, and the residual type of schizophrenia. So you had to make a diagnosis and put them in the little category as to whichever category they're in. Now they're saying, no, people have a combination of all of those 5 characteristics. And that's what we're dealing with. And then we look at severity, and so it's sort of an overall scale. So that's why this is sort of a spectrum disorder that we're talking about here. Now, there are other things that can have psychosis, and you have to be careful not to get confused here. Because you can have mood disorders with psychosis, which means they primarily have a mood disorder, but they're having hallucinations or delusions. Cognitive disorder with psychosis, especially if they're demented, they can have those kind of things. All the personality disorders, like borderline personality disorder, we'll be talking about that later, can have psychosis involved with them. So just because somebody has a hallucination, does that mean we should give them a diagnosis of schizophrenia? No, not at all. That could also be a whole spiritual problem. That would be dissociative identity disorder. We have to sort all those things out. As we said, this isn't easy to sort all this stuff out, but we have to understand this as we go along. Disorders that masquerade as psychosis. Specific phobias can be so strong that they act that way. Intellectual disability, and that is what used to be mental retardation, if you remember. Okay? Somatic system disorders. In one particular case, I was working with this boy, and he had a somatic system disorder, meaning that he was having seizures, but they weren't real seizures. We'll talk about that later. But he was also seeing spirits and seeing walls close in on him and having friends and all sorts of other things that were going on. But they really were a stress-related type of situation. So they really weren't schizophrenia itself. It was paranoia that was coming from anxiety. So how do we distinguish schizophrenia from the other disorders? Well, the first thing is the length. Remember that? We said the other things that we called it different names, but only after 6 months that we then say that we would diagnose schizophrenia. Negative symptoms. Remember I told you about Jacob, of how he just couldn't function. In these cases, you're not going to have anyone that's totally functioning just fine and only have one issue or something like that. That's probably going to be a brief psychotic disorder or some of the other kind of things we're dealing with here. As we said, it has to go at least 6 months, but some other things, there should probably not be, the person shouldn't be functioning perfectly well, boom, this happens, and now they're functioning perfectly well. Because normally those negative symptoms are going to make the person pretty dysfunctional, and they're going to have a hard time coping in life. See, it's a whole picture of this whole thing together that you're looking at. And so if that's the case, you ought to look for other diagnoses to see what you're dealing with there. So what are the causes? And this is one of the areas we don't understand very well, but we have a few things put together that make some sense as to what's going on here in the particular person. Genetic disposition, 10% among first-order relatives, but 40 to 60% among identical twins. You know, identical twin studies, what they do is they try and find some identical twins that have been split up at birth. And then they see what is the probability that they both have schizophrenia. And of course, if they both have schizophrenia brought up in two different families, that eliminates the family culture. So therefore, you're saying this has to have a genetic factor here. And that's 40 to 60%. There's a genetic factor. You're going to find that these people have other relatives that have these same kind of problems. So it's one of the questions you want to ask all the time. So what are some of the theories or models? Excessive dopamine, which is a neurotransmitter in your brain. That's why you get a high when you take meth, as an example, is you're kicking off dopamine. But of course, what have you done? You've used up your dopamine, so now you crash. Antipsychotic drugs bind with the dopamine D2 receptor. They're basically, standard antipsychotics work in one particular area dealing with dopamine. And we're going to see there's a second one here. Too little dopamine, and you have Parkinson's disease. So how'd they sort of discover this? If somebody with Parkinson's disease, you give them a lot of Levodopa, and you give them too much, and guess what happens? They act schizophrenic. Person that's schizophrenic, and you give them too much medicine, they can start shaking like they have Parkinson's disease. So do you see it's an extreme in this particular type? There's more types, though. We'll have to talk about it. Some taking too much medicine develop the symptoms. Amphetamine psychosis triggers the dopamine release, as I already said. But the second type, type 2, is excessive serotonin, and there are more negative symptoms in the second type of schizophrenia. And you use what are called atypical antipsychotics. Ever hear of Abilify, or clozapine, or Zyprexa? Those are some of the new ones that they're using, and the difference is it binds with D1 and D2 receptors for dopamine and serotonin. So you have sort of two different types here of schizophrenia, but they have a lot of the basic same type of stuff, and so you use different medications for the different types. Abnormal brain structure. When they look at the brain, they find out in a lot of cases, but not all. And also, just because you have this brain structure doesn't mean you have schizophrenia and so on. But it's one of the characteristics. And people that have these ventricles enlarged on the left side have more negative and fewer positive symptoms. Poor response to drugs. So again, do we really know? Not totally. But we know that there are some hints that we have of what's going on here on the physical part of this thing. As I said, in the spiritual part, I believe the person isn't defending their brain, and therefore spirits are able to take advantage of the psychological or the physical holes that they have in their life. There are all sorts of interesting theories. Most of these have been negated at this particular point, because the psychodynamic people used to feel it was regression to primary narcissism. Behaviorally, a lack of reinforcers. Maybe that applies to a little bit, but generally we're saying we have a physical problem here, then we have stressors, and the stressors tend to kick it off. See, why doesn't everybody get schizophrenia that comes from that same family? Well, it seems to be triggered by stressors in the person's life in addition to the different physical things that are going on in the person's life. Cognitive, biological problems lead to trying to cope with strange sensory experiences that are going on in the person's life. So treatment. One of the things that's very important to realize here, if you really have a person with schizophrenia, the sooner you get them medication, the greater the chance of their recovery. So you don't want to just put off, and we're not sure if this is it or whatever. You're better off to do the medication and try to get some control of this as early as possible, because there's a much higher probability of recovery from this if you catch it right away than if it's gone on for years and years and years and years and years. One of the problems that we have is that some of these different drugs have their own problems on the side. Some of the original ones like Haldol and have such strong problems that people don't even want to take them. We've got some of the new ones which are great and they can really help and don't have as many side effects. But some of the things from the classical antipsychotics, the more earlier ones, dystonia, involuntary muscle contractions. Their muscles are just contracting. Akinesia, restless or agitation. Epileptic, malignant syndrome, muscle rigidity, fever, altered consciousness, automatic dysfunction that can lead to death. So just by taking this medicine, if you don't watch it and take control, the person can die. Because that's how strong this stuff is, it can have an effect. And the most usual one, Tardive Castensia, where for more than a year, involuntary tic-like movements of the tongue, mouth, and the whole body. 20 to 30% to some degree, especially in older people, possibly higher. This is normally for this type 2 schizophrenia. And it's usually from clozapine, and many times they can't ever recover from that. They're stuck in that, they never get better. So that's why people like to go to these newer antipsychotic ones, because they deal with some of the other, but again, they try different things. I just had a client on Haldol again, which is one of the first ones that ever came out, which meant they tried other things. Please understand, medication isn't the answer to everything here, and some people will not get rid of their delusions or their hallucinations just because they're given medication. But the majority will be able to function to the point they can live in their apartment by themselves, live off SSI, sort of do jobs to a certain degree and function to a certain degree in sort of an odd way. So they don't really fit in. And so by supporting systems that we have in society now, where they have different places they can go during the day and so on, they can reasonably function in society. But what happens if they don't take their medication? Then sometimes they can relapse. A sad story here in Wichita, just as when this comes home. Down by Rock and Kellogg, there was a man and he was walking on the meridian between the street. And there was a schizophrenic that wasn't taking his medicine, and a voice told him, run him over, and he did. Many times these critical things that you see, where there's shootings and all those kind of things, have a relationship in this particular areas because they might act on what the spirits tell them. So the Bible point of view, is there any of this stuff in the Bible? Well, how about the case of the demoniac? Let's look at that for just a minute, and let's just see how many of these symptoms we see when we read this story. Now notice something. How did Jesus handle this? He cast out the spirit. So this was primarily a spiritual attack versus a physical thing. Jesus could have healed him, but Jesus chose to cast out the spirits, right? And when they came out of the ship, this is Mark 5:2, immediately there met him out of the tombs a man with an unclean spirit. That's negative symptoms. Unclean spirits give you negative symptoms. Who had been dwelling in the tombs, and no man could bind him, no, not with chains. Now what does that tell us? Well, people with schizophrenia normally don't have superhuman power, do they? Okay, so if you've got superhuman power going on here, you probably are dealing with a spirit, but it could be a combination of both. because he had often been bound with fetters and chains, and the chains had been plucked asunder by him, and the fetters broken in pieces, so no man could tame him. And hours, night and day, he was in the mountains and in the tombs, crying and cutting himself with stones. So this could be a schizoaffective disorder. It could be borderline personality, where the person is a cutter. Those kind of things. Now let's look at the description in Luke 8:27. And when he came forth to the land, there came to meet him out of the city a certain man who had devils long time and wear no clothes. Again, the disorganized behavior. Neither abode in any house, but in the tombs. When he saw Jesus, he cried out and fell down before him with a loud voice, What have you had to do with thee, Jesus, thou Son of the Most High? I beseech thee, torment me not. For he had commanded the unclean spirit to come out of the man. For oftentimes it had caught him, and he was kept bound in chains and fetters. And he brake the chains and was driven by the devil into the wilderness. And when the devils came out of the man, they entered into the swine. And the herd ran violently down into the steep place into the lake and were choked. But do you see the kind of things we're talking about there? He's affected, but how do we sort this whole thing out? All we can do is believe Jesus knew what he was doing. This was primarily a demon possession thing versus a schizophrenic thing. But can you see how it could all be combined and confused as to sort out what's going on with the person? Now, question is, what are the outcomes? How much can people be helped in this particular area? And I said it's going to be a combination of the medication, of trying to deal with spirits, of trying to deal with the things that have happened to this person that caused the stress, of dealing with their choices. So it's a whole spectrum thing, right? Okay? 10 to 30% require continued hospitalization. 25 to 40% return to their homes on medicine. Most survive on government disability pay. 30% of the street people have some sort of a severe mental disorder like this. 4 to 30% recover completely. So if you're dealing with these people, this is an ongoing, lifelong thing for a lot of them, but in some other cases, sometimes the medicine, sometimes just dealing in the counseling and so on, you'll be able to understand this and work these issues through. So SPEC, what are we talking about here? Well, primarily in this particular area, we're talking physical again as the primary component, but we have a very strong spiritual component. And remember the stress, that's the experiential component and the choices the person makes. So this one is all of them and sorting all of this stuff out. And that's the difficulty, and that's why we need the Spirit of God, and that's why we need the Holy Spirit speaking to us. So like Jesus, we can choose the right way of treating each one of these situations. See, like this man from Jordan. He was talking about, see, they're treating everybody as a spiritual demonic possession. And he was not getting real good results in a lot of cases. So he was trying to understand, okay, more of this of how the pieces fit together, because one size does not fit all. Let's pray. Lord God, we thank you that you are God and you can heal people, and you can deal with spirits, and you can deal with all these different issues in a person's life. And we ask for your wisdom. We admit that we can't do this. We admit that we don't have the answers. But Lord, that you would put it together in each situation, that you would help us to recognize the problem, do what needs to be done to get the greatest healing and help for these hurting people. In Jesus' name, amen.